Hi everybody and welcome back to my channel. Today I will be talking about a condition called Myasthenia Gravis. This is characterized by muscle fatigue and weakness, and it can be a very debilitating condition, as not only can it affect the eyes, it can also affect the breathing system and apparatus, as well as the GI tract, particularly notably swallowing. So if you want to learn more about this, then please stay tuned. In the condition of myasthenia gravis, there are autoantibodies which basically imply certain components attacking one's own body. This then culminates in a classic combination of signs and symptoms that manifest in how patients present. It is a rare condition, and some prevalences state it is as rare as 1 in 10,000 people. In terms of who it tends to affect, it usually affects patients roughly in the second decade of life and then in the sixth decade of life. Classically, it has a slight bias towards females compared to males. It can also be associated with other autoimmune conditions such as thyroid eye disease, Graves' disease, etc. From an eye perspective, the key features that tend to be found include eye movement abnormalities that are highly variable, non-specific, and tend to be generally a bit confusing to the eye care practitioner. Patients will present typically with eye movement abnormalities, diplopia, which is double vision. Another classic reason they present is a lid droop, which they state varies from day to day and varies over the course of a day itself. The other thing to note about myasthenia gravis is that it can occur purely as an eye problem, or it can also occur as a generalized condition where the eyes are also implicated. A classic way to ask patients to try and manifest an underlying myasthenia gravis type picture is if you ask them to look up, for example, at a target, and you ask them to maintain that particular gaze over time, the eyelids, for example, will start to droop down. In terms of the eye care practitioner, other signs can also be seen, including variability within a clinic, a particular test known as Cogan's lid twitch. Cogan's lid twitch involves asking the patient to look down for approximately 30 seconds or so at a target. Then when you ask them to look back and refixate into the primary position, the lid will overshoot and then recorrect itself. A couple of key questions to ask patients if you suspect them to have myasthenia gravis are: do they have any swallowing problems? Do they have any breathing problems? Because these can be life-threatening. Other things that patients may also report are things such as difficulty swallowing liquids and generalized fatigue in their upper and lower limbs. In terms of patients who are suspected of having myasthenia gravis, they will be classically evaluated clinically, and you can usually establish a strong clinical suspicion based on tracking them over time, i.e. a couple of clinic appointments and seeing variability in terms of eye movements, in terms of ptosis, and then blood tests are classically carried out to try and look for autoantibodies to acetylcholine receptors. Some specific antibodies can be even more specialized than this, but that's beyond the scope of this particular video. It is also worth noting that some patients can have all of the features of myasthenia gravis clinically, however their blood tests will come back as negative. These patients are labeled as clinically positive but biochemically negative myasthenia gravis patients. Other more specialized testing can also include specifically testing muscle fibers to look for fatigability over time. Patients will also have scans performed to look for a thymus gland, and this may be done with either a CT or an MRI scan. One very neat test to mention, which I have personally done myself and found it to be fantastically effective in the small cohort that I have performed it on in terms of patients, is the ice pack test. So if a patient is found to have lid ptosis, if one gets an ice pack or an ice cube, places it on the eyelid and then places it there for approximately 2 minutes or so and then removes it, what you're looking for is a change in the position of the lid of roughly 2 millimeters to signify that there is reversibility. This can be a very important diagnostic clue. In the historic past, other tests were also performed. However, due to safety issues with them, they are now very rarely done. The test I'm specifically referring to is the hydrophonium test. Myasthenia gravis is a condition that requires multidisciplinary input and management, so they'll be classically be seen by neurologists as well as ophthalmologists. The key to treatment is to immunosuppress the patients, and this can include several different groups of medications, and ultimately the goal is to try and suppress the immune system, which is firing these autoantibodies towards acetylcholine receptors and therefore causing the symptoms that the patients are experiencing. The reason for performing a CT and MRI scan to look for a thymoma is because if it is present and the patient has myasthenia gravis as an underlying diagnosis, then some advocate to remove this gland because it has been implicated in having adverse outcomes in terms of management of myasthenia gravis patients. Patients with myasthenia gravis will then be followed up in clinics regularly, and this will allow titration of the medications that they are on, and this will be done obviously factoring in how symptomatic the patient is and the signs that we see as eye care practitioners and or neurologists. Thank you so much for watching this video about myasthenia gravis. I hope I've provided you with an overview of what it is, how it can present, and how it is managed. If you like this video, please click the like button, the subscribe button, and click the bell icon. Thank you so much.